Alright, so this is the last video for NBME 20. We just finished the entire test. Now, throughout the test, we did see some questions that popped up multiple times, some questions that were about the same topic, but in different ways. So if you're preparing for an NBME, make sure you know what are looking like high yield topics for NBME, right? High yield topics for NBME are very different from high yield topics for step 1. And there are a couple topics that are only on step 1 but not on NBME. Like, you don't really see many questions on cardiovascular heart sounds or cardiovascular loops and curves, respiratory loops and curves. It's a pretty rare thing on NBME, so that's one way. Alright, so let's get this thing started now. So right now, question number 26. A previously healthy 16-year-old girl is brought to the physician by her 18-year-old sister because of a 2-day history of a thick, yellow vaginal discharge and burning with urination. Alright. She does not want her parents to know that she is sexually active. Her temperature is 98.6, pulse is 80, and blood pressure is 110. Examination shows a mucopurulent discharge at the cervical os and fragility of the cervix. Uterus is small, firm, and non-tender. No adnexal masses or external vaginal lesions. Gram stain of the discharge shows gram-negative diplococci, basically hinting at Neisseria. And urinalysis is normal. Testing for Neisseria and chlamydia is ordered. Which of the following is the most appropriate course of action? So without even looking at the answer choices, you should know that you have to go help the patient, and that's like number 1. And just do whatever the patient needs help with, right? So she's brought... She herself is 16, and she's coming with her sister, who is 18. Right, so a 16-year-old girl is brought by an 18-year-old sister. Perfectly fine. So now you look at your answer choices. Do not prescribe antibiotics. That's stupid. Obtain written consent from parents. This isn't school. First of all, there are a couple things you're never supposed to bring up to parents. And if a child comes in asking for help with an STI, that's one of them. Because you want the patient to be comfortable in sharing things with you, not scared as if you're going to go tell everything to their parents. So you can automatically knock out B and C. Prescribe antibiotics and notify your parents, that's stupid too. So it's just E. Prescribe antibiotics without notifying her parents. Sex, drugs, and any emergency or trauma do not really require parental consent or notification at all. Just remember to encourage healthy minor-guardian communication and a minor's assent, right? Not consent, but assent. Basically making sure that the minor knows what you're going to be doing, right? So you're not going to ask the minor, hey, do you want me to give you antibiotics or something like that? No, you're going to give them antibiotics and let them know why and how it's going to work, right? So that's the thing. Yeah, definitely do AMBOSS. I would highly recommend doing AMBOSS. I also feel like repeating UWorld. A lot of people repeat UWorld, and that's something everyone's been doing. But repeating UWorld can be quite a burnout and really annoying and boring. So AMBOSS is different. It's similar topics, but different ways of being questioned on it, different images, you know, a lot of different things. Totally worth doing. Yes. And their visual explanations are wonderful. That's why I had to grab a bunch of it and put it into my first aid, because it's just so helpful. 27 to 45-year-old woman who is intubated and mechanically ventilated develops fungemia with Candida albicans during a prolonged hospital stay. Treatment with caspofungin is started. Which of the following features of the causal organism will most likely be targeted by this drug? So all the fungin medications inhibit cell wall synthesis, and this is something you really need to get down. It's used for invasive aspergillosis and Candida. Adverse effects are GI upset and histamine-induced flushing. Right, so these are all the echinocandids. So that would be B. Beta-glucan carbohydrates in the cell wall. If you look at it in first aid, this is a page you should have printed out in your hand so you can look at it more often. Not that one. This page. This thing. Right, antifungal therapy. Also the antimicrobial therapy. So for the cell wall, the only thing you have are the candids. Anidula fungin, caspofungin, micofungin, these guys target the cell wall. Squalene epoxidase works with the terbinafine guy, right? Everything that ends in azole, all these azoles work over here between lanosterol and ergosterol, mostly with the ergosterol synthesis inhibition. Polyenes like amphotericin B and nystatin, which are really terrible and problematic medications, they work at the polyene stuff, the yellow thing here, right? So that's part of the cell membrane integrity stuff. And flucytosine is the only nucleic acid synthesis medication used for fungal therapy. So make sure you know echinocandins, and well, make sure you know all of them, to be honest. You can't do anything about that, but you should also be able to associate each one of these acid choices with a specific medication if you're preparing for step 1. So you should know what A, B, C, D, and E are for, or maybe they're not even actual medications. A 27-year-old man comes to the physician because of weakness of his left hand for 3 weeks. He is a professional athlete and rides a bicycle for 8 to 10 hours daily. He has been unable to grasp the handlebar with his normal strength, making it difficult to train for a full day. He has no pain or numbness. Physical exam shows mild weakness with abduction and adduction of the fingers. He is unable to hold a piece of paper between the thumb and the side of the index finger, which is apparently known as the Froment sign. Sensation is intact. The most likely cause of these findings is the compression of which of the following structures. So anytime you have a question about bicycle riders, right, bikers, long-term bikers, especially like him, 8 to 10 hours daily, that can lead to Guillain-Canal syndrome. You have to remember Guillain-Canal syndrome, where you basically have compression of your ulnar nerve. There you go. Oh man, yawning is fun. So carpal tunnel syndrome is the one with your median nerve, right? That gets compressed under the flexor retinaculum and all that. Your Guillain-Canal, let's take a look at that. So page 503. So Guillain-Canal, they show you, it looks like this. So UWorld had this image of the ulnar trap, right? You can see you have your pinched ulnar nerve with this, the Guillain-Canal being the space under your pisiform. Alright, so Guillain-Canal syndrome, compression of the ulnar nerve at the wrist, classically seen in cyclists due to pressure from handlebars. The hook of hamate bone is related to the Guillain-Canal syndrome. The adductor pollicis muscle, which adducts the thumb, abductor, flexor, and opponens digiti minimi are all innervated by the deep branch of the ulnar nerve. And the abductor, flexor, and opponens digiti minimi, those are all minimi, the muscles for your pinky. The Froment sign is when you can't hold a piece of paper between the thumb and the index finger. Right, so like that. That issue occurs from this also because of the pain. Alright, and this was another UWorld question about the same kind of stuff. Right, but sensation was also affected for her, so you know they can do weird things like that. But if you look at all your answer choices, A is the only one that makes sense. Hook of hamate, ulnar nerve, they're both mentioned in this question. I mean, in this answer choice. That is Guillain-Canal syndrome. Guillain-Canal syndrome is the hook of hamate one. For the other bones of the wrist, we look at the actual wrist itself. Sorry, where is it? Yeah. So from the bones of the wrist or the wrist region, right, you need to make sure you memorize this. You should understand what hand you're looking at based off the radius and ulna. And then in the middle, you're always going to have the big landmark, the capitate, right? This is your scaphoid and lunate. So you should memorize these three for sure, right? The most important ones to know are the big ones. You don't need to worry about the T's and the pisiform, but you need to know these four big guys. Capitate, hamate, lunate, and scaphoid, right? The scaphoid and lunate are discussed here. They tell you that dislocation of the lunate may cause acute carpal tunnel syndrome. And scaphoid, which is palpable in the anatomic snuff box, and you would have pain if it's issued, if it is fractured. Scaphoid is the most commonly fractured carpal bone, typically due to a fall in an outstretched hand, and you can get proximal scaphoid features causing avascular necrosis, and that's going to be a problematic, painful spot right here on your hand, right? So they're showing you right here, coming from the radial artery, right? So scaphoid and lunate, the hook of hamate, which we just saw earlier, can cause Guillain-Canal syndrome in bikers due to ulnar trapping under the hook of hamate. Okay, this is a gross image of the brain, and you see a 65-year-old woman. So that's a really, really old woman. Dies 6 months after the onset of severe headaches. Her brain, as seen at autopsy, is shown in the photograph. Which of the following is the most likely cell of origin of this neoplasm? Now, the first issue when you see such an image is identifying the neoplasm. You know, that's the first thing that comes up. and then you look at your answer choices, and we're in my regular neurology streams, we're up to the adult primary brain tumors, and then we'll talk about childhood primary brain tumors. So those, the adult brain tumors we're looking at an adult right now. Those include the glioblastoma multiforme, oligodendroglioma, meningioma, which occurs more commonly in females. Hemangioblastoma, a very rare one, occurs in the cerebellar. We already know about the pituitary adenoma, and we already know about the schwannoma, right? Those are things you've seen before. So looking at her, from our answer choices, we have astrocyte, endothelial, melanocyte, meningeal, and squamous epithelia. Her brain, as seen at the autopsy, is all we've been given. There's nothing else given. We're really just working off the fact that she has an autopsy, the fact that she's 65 and she had headaches for 6 months. So the headaches should remind you of an irritation of the meninges, right? That's how you pick the answer here. Her headache is due to a meningeal thing. So this patient has a meningioma, and like we just saw right now, meningioma are more common in females, typically benign, which is why she had it for 6 months and nothing happened, right? Extraaxial, so there's going to be an external to the, the tumor itself will be external to the brain parenchyma and may have a dural attachment tail. Often asymptomatic, may present with seizures or neurologic signs like headaches. Resection or radiosurgery can help. So this is another one of the guys that has the Samoa bodies. That's another thing you need to remember. And the tail they're talking about, image E, that's like this. So you see the meningioma and you have the tail on both ends? That's what this patient has. So that's her meningioma right there. That thing. Right, everything else in between over here, it's all just brain, normal brain. But this thing is weird. This is not an actual thing you're supposed to have in your brain, right? There's no big round little thing in the back of your brain like that. So you just pick that and you move on, and that's it. So there were a couple of hints to pick meningeal, but for the most part, depending on how well you remember your neurological tumors, you would be able to pick it. Otherwise, you would just end up picking something that makes sense. Things you could definitely knock out are squamous epithelial and endothelial. Those two you could definitely knock out. Right? Melanocyte would mean that you're talking about a melanoma that metastasized to the brain, and they didn't give you anything about any melanin issues, so you might be able to knock it out and leave yourselves between astrocyte and meningeal. But look at the astrocyte one. The astrocyte one is very special, right? So glioblastoma multiforme is a grade 4 astrocytoma, which is highly malignant, and it's found in the cerebral hemisphere, right? It's a butterfly glioma. So you can see in image A, right? You see how it looks like right here, right? That's your glioblastoma multiforme. It is possible to think that this is also that, but it's not. This isn't your cerebral hemisphere. This is under the brain now. Right? Cerebral hemisphere is higher in the brain, upper area of the brain, not under the brain like they gave it to you. So it was a slightly difficult question since all they gave you was a gross image to work off of, but it does the job. A study is conducted to identify healthy women at risk for cardiovascular disease. Because atherosclerosis is an inflammatory process, the concentration of plasma C-reactive protein, a marker of inflammation, is measured. The plasma CRP concentration is increased in women who subsequently develop coronary artery disease. Which of the following is the most likely site of CRP biosynthesis? So this entire question was unnecessary. All they really want to ask you is, where do you make CRP? And that's a really easy question. CRP is made in the liver. In fact, all of those acute phase reactants that are made in the liver are discussed right here in one place. Plenty of fish in the sea. Right, so acute phase reactions, more fish in the sea. Right, so positive or upregulated and negative downregulated. These are all reactants that get either up or downregulated when you're sick. So ferritin, fibrinogen, serum amyloid A, hepcidin, and C-reactive protein are all made in the liver. It's really important to make sure you know that. Acute phase reactants. And then the next page talks more about ESR stuff. Right? Albumin Transferrin. So good stuff here. Really straightforward question. If you completely forgot about it, then you really wouldn't know what to pick here. I mean, of course, it's not made in the heart. Bone marrow is really just known to make blood and stuff. You could possibly think maybe it was a spleen thing, but to be entirely honest, all these other answer choices don't make any sense. Definitely not thymus, definitely not spleen, definitely not heart, definitely not bone marrow. The liver is a big factory of making proteins of all kinds, so liver would be the correct answer. Right? Other positive ones, negative ones, like we saw on the page, so that was it. 31. A 58-year-old man is brought to the emergency department because he has had severe chest pain radiating to the back for the past 30 minutes. X-rays of the chest do not show widening of the aorta. Aortic angiography shows an extra lumen in the media of the proximal aorta. Which of the following is the most likely cause of this finding? So severe chest pain radiating to the back, and then you have an extra lumen. That's all related to hypertension. Right? This patient has an aortic dissection. Hypertension causes a rip to make another lumen inside the lumen. So you have a false lumen. Let me show you page 322. Okay. So what we're looking at is this. You have another lumen inside the lumen, right? This scenario that they gave you here is really bad. It's in the ascending and the descending one. So you have it in the ascending and the descending one. But it can be either in one or both places, and that's what you really have to worry about. So this is aortic dissection. Strictly due to hypertension, not related to smoking. Make sure you don't pick smoking as an answer choice. They didn't even put that as an answer choice here, but they could have. Alright, so it's not due to smoking. Smoking has nothing to do with aortic dissection as far as step 1 is concerned. A 51-year-old man develops diaphoresis, tachycardia, and a blood pressure of 155/100 24 hours after undergoing an abdominal operation. 2 hours later, he has a generalized tonic-clonic seizure. Which of the following is the most likely responsible for these adverse effects in this patient? So you're seeing all these random things. The first thing you want to do in your mind after reading such a question is understand that the patient had a surgery, and the surgery did not really have any complications as far as we can see, right? No complications. If we look at our answer choices, they don't mention, oh, it was complication of surgery. So we can forget the fact that this guy even had a surgery and really focus on the fact that this is a 51-year-old man presenting with diaphoresis and tachycardia 24 hours after just chilling and not doing anything special, right? Doing things you would be able to do at a hospital, which is really just laying there and eating healthy things. So now, and then even 2 hours later, it has a seizure too. That seizure is what you have to remember is a sign of alcohol withdrawal right there, right? So patients who are hospitalized can't drink. This man must be an alcoholic. Since he hasn't been able to drink for 24 hours, now he's having symptoms of alcohol withdrawal, right? So in the first 24 hours of surgery, the patient started exhibiting diaphoresis and agitation. The patient was likely in the hospital for longer than 24 hours though, so as more time went on, he is now experiencing withdrawal seizures. There is no information for us to be able to pick any other answer choice, like acute renal failure, anaphylactic reaction, narcotic pain medication, or sepsis from a gram-positive organism. Right, so alcohol withdrawal is a very common thing. You can get patients who are alcoholics and they look fine because they're still getting their alcohol. Right? They might be rich people that are alcoholics and they just maintain themselves really, really well, but they're still addicted to alcohol. And 3 to 36 hours is when you start getting random insomnia, GI upset, diaphoresis, and tremors. Within the 48 hours though, the same 6 to 48 hours, you can get withdrawal seizures. Right, so after 3 hours, you might start seeing these things. After 6 hours, you can start seeing withdrawal seizures, depending on how dependent and how long you've been a chronic alcoholic for. Right, the longer, the quicker. 12 to 48 hours, so after 12 hours, you can have the hallucinosis happening. And after 48 hours, you get the worst case scenario, delirium tremens. Right, treatment is the real answer for treatment. Yeah, sure, benzodiazepines is fine, but inside the hospital, once the patient admits that they are an alcoholic, the immediate way of fixing them up is to give them some alcohol. It's not necessarily just a benzodiazepine. So I got to see this when I was at Emory Hospital in Atlanta, that if you have an alcoholic patient and they really need the treatment immediately and they're having like crazy withdrawal symptoms, that hospitals actually carry beer. They actually have beer cans for such patients. You just give them that one can, they drink it, and they'll be okay. Then you get them in the right mental capacity and you start treating them. So that's something you want to keep in mind. That's a very realistic clinical setting picture right there. A 55-year-old man comes to the physician because of a 2-month history of decreased appetite. He also has had 20-pound weight loss and an intermittent rash during this period. Physical exam shows necrolytic migratory erythema over the axillae and groin. As soon as you see that necrolytic migratory erythema, that needs to ring a bell for something from endocrine. That would be your glucagonoma. Lab studies show a serum glucose concentration of 280, plasma glucagon concentration that's super high, which basically gives away the fact that the patient has glucagonoma. So even if you didn't think about it, they were nice enough to give you information for you to know it. A CT scan of the abdomen shows a mass at the head of the pancreas. Which of the following processes is most likely occurring in this patient's liver? So basically they want to know, what does glucagon make you do? Glucagon is the opposite of insulin. So if insulin makes you do it, glucagon does not make you do it. So knock out anything that has to do with insulin and keep the things that have to do with glucagon. So now you start looking at it. Decreased activity of carnitine acetyltransferase. That, right, CAT1 and CAT2 are important enzymes of fatty acid beta oxidation. Remember the carnitine shuttle, and glucagon upregulates this process. Right, so it would not be decreased activity, it would be increased activity. So let's take a look at that real quick. Let's see, right here. Right, carnitine and the citrate shuttle. Right, the citrate shuttle is a whole different thing. This is anabolic. Insulin is anabolic. Catabolic would be glucagon. So fatty acid going this way, and then you making ketone bodies, right? So that means the inhibition of ketogenesis is also the wrong answer. Right? Acetyl-CoA carboxylase. Sorry, glucagon increases ketogenesis. What else is there? The correct answer is B, glycogen synthesis. C, increased activity of acetyl-CoA carboxylase. What does that have anything to do with? So glycogen formation is inhibited. Oh, wait. What am I saying? The correct answer here is E. My bad. Let's just go through all of them, but I do want to talk about this one first, because this one was a common answer choice many people picked. C. So correct answer here is E, partial oxidation of fatty acids, which I just said, right? That this part, the catabolic part, is the one that glucagon upregulates. Insulin is anabolic. Insulin upregulates this part where you make fatty acids. Insulin makes you fat. Glucagon makes you skinny, right? So glucagon causes fatty acid breakdown, which you can then use to make ketone bodies. You have to remember that. This patient is going to have increased partial oxidation of fatty acids, which is what's causing his weight loss. His intermittent rash is related to the glucagonoma. We're going to take a look at that too. Glycogen synthesis, remember that glycogen formation is inhibited by glucagon because glucagon is breakdown of glycogen, right? That's like a common sense thing. There's no way you could pick B, right? Glucagon breaks down glycogen to make more sugar available for you, so that glucose can be used by cells. Increased activity of acetyl-CoA carboxylase. What is that related to? Acetyl-CoA carboxylase is used for fatty acid synthesis and thus would be decreased by the glucagon, right? So decreased. Right here, you can see acyl-CoA synthetase, fatty acyl-CoA, right? You're going to use it, so it's going to be decreased. You're going to use it all up. You're going to use it all up. It's all going to go through the carnage shuttle, the carnitine shuttle. And carnage is like eating or breaking down. So that, this question was not that hard. It is a biochemistry / endocrine type question, but they gave away the fact that it's a glucagonoma, and all they really wanted to know was, what is all that glucagon going to do? They didn't really want to know too much about a glucagonoma per se itself. Glucagonoma is discussed in endocrine, where they tell you about this really weird rash, right? Insulinoma and all the other guys are there too, but the other guys don't really have anything like that. So let's see, right here. So if you have your insulinoma, we should know what insulin causes, and a lot of insulin is just going to make you really fat and stuff like that. You can have a lot of weakness, hypoglycemia, right? Because all your sugar is being used up with insulin. Insulinoma is also related to MEN1. Glucagonoma, this one, causes a tumor of the pancreatic alpha cells causing overproduction of glucagon, presents with the 5Ds, and you should remember the dermatitis. The first thing you should remember is dermatitis. It's the only one you need to remember for glucagonoma because everything else kind of makes sense. So that's the necrolytic migratory erythema, which I described a little more here. Lesions become necrotic, then slow off or form indurated plaques with brown-bronze color. And they can occur anywhere. They're painful erythematous lesions affecting the face, groin, and extremities. Of course, glucagonoma is going to cause diabetes because you're going to have a lot of sugar in your body now. It can cause a DVT. That's the other important thing you need to remember from glucagonoma. The dermatitis and the DVT. Of course, glucagonoma causes declining weight and depression and diabetes. Those are given. But the DVT and the dermatitis are the special ones. I definitely want to make sure you remember that. So this question was pretty easy though. They just wanted to know how glucagon works. That's it. 34. A previously healthy 37-year-old woman comes to a physician because of a 6-month history of fatigue. She has had 18 kilograms weight gain during this period. Her temperature is 99.7, pulse is 85, respirations are 12, blood pressure is 190/95. That's pretty crazy. Physical exam shows a round face and truncal obesity. There are purple striae over the abdomen and flank, and ecchymoses over the forearms and lower extremities. Pelvic exam shows no abnormalities. Her plasma adrenocorticotropic hormone, ACTH, concentration is less than 5. Her serum cortisol concentration does not become suppressed following administration of low and high doses of dexamethasone. That's the giveaway for what's wrong. For which of the following is the most likely cause of these findings? So clearly this is a question about Cushing. And then they did the dexamethasone suppression test. Now remember, dexamethasone is a zone. It's like prednisone. So if you're giving someone corticosteroids, it should cause suppression if you're actually working with the problem originating from something within the feedback loop. The feedback loop includes the pituitary. If this patient has a pituitary issue, then if I give more corticosteroids, that feedback will stop you from making more ACTH. It had no effect on this patient, right? That means that this is an adrenal gland issue where there's a problem with the adrenal gland. So we can knock out B, pituitary basophilic adenoma, and then ectopic ACTH production. This is just a trick answer choice, right? This is a trick answer choice that a lot of people fell for. But we weren't given any real information for where ACTH is coming from. In fact, they even tell you her plasma ACTH is low. Right? Her plasma ACTH is low, so for the most part that it's not really a pituitary thing, nor is it related to ACTH. So you can knock out A and B because your pituitary is the one that makes ACTH, but your ACTH is already low. That means that you're making too much cortisol from your adrenal gland by yourself. The adrenal gland has a cancer that's making too much cortisol. You're not making too much cortisol because you have ACTH. Right? So doing the dexamethasone suppression test was already kind of unnecessary here to begin with, because your ACTH is low. If you go back and look at it, and you got to make sure you're very confident with this entire flowchart here. But when you measure serum ACTH and it's low, you don't do the dexamethasone suppression test or C-reactive stimulation test. If your ACTH is low, that means you have an ACTH-independent Cushing syndrome, which means you're either eating a lot of corticosteroids or your adrenal gland has a tumor. Both of which are good prognosis, and you can work with it. You can either remove the adrenal gland or stop taking the corticosteroids and treat the patient. If you measure ACTH and it's very high, then you want to see if you're able to, influence that ACTH. If the ACTH is coming from the pituitary, then you're able to influence it with dexamethasone or CRH. If giving dexamethasone or CRH has no effect, then it's not ACTH from the pituitary. It's actually ectopic ACTH from some kind of lung cancer. Right? So that's where all of that comes from, small cell lung cancer. So ACTH is low. So it's not a pituitary adenoma, and doing anything dexamethasone suppression or serious stimulation is not needed. When ACTH is low, you immediately know it's an ACTH independent and is probably due to either exogenous glucocorticoids or an adrenal tumor. This patient seems to have an adrenal tumor, and glucocorticoids come from the fasciculata. Right, so C, that's it. All right, you would not pick glomerulosa reticularis. All right, that's that GFR. Remember the GFR stuff. So if we go to right here. If we come to this stuff, right, that's your GFR. Glomerulosa is the one that makes the mineralocorticoid aldosterone. F is for cortisol, reticularis is DHEA, the androgens, right? So this patient has a cortisol issue, and that's why you would just go with that. So blood pressure is 190 because of that excess cortisol. I don't really know what the IFOM exam is. 35. A 60-year-old man has a round, semi-transparent nodule on his nose. Semi-transparent nodule. Okay. Examination of tissue obtained on biopsy shows small basophilic cells forming tumor islands surrounded by clear spaces and extending across the basement membrane. Which of the following is the most likely diagnosis? So those tumor islands that they're talking about, and then the extension into the basement membrane, are all a giveaway for basal cell carcinoma. The description they gave is for palisading nuclei. In addition, the other answer choices are either pigmented or have scales, right? Actinic keratosis is pigmented, a nevus is pigmented, melanoma is pigmented, and seborrheic keratosis has scales. So they're all not being described. Palisading nuclei, palisade, the word palisade is for having a fence. If you make a fence around something, that's palisading. So now what they just told you, right, tumor islands, that means that things are fenced. There's a fence making an island. That is a palisading nuclei. Well, if it's an exam about medical stuff, and if it's even similar to step 1, I would just directly recommend using UWorld and Amboss, because not only do they have really good questions, the explanations for the questions are world class. They're just such good explanations, both UWorld and Amboss. You get all these explanations with good images, also an explanation of what the wrong answers are and why they're wrong, so you can really learn. Yeah, okay, so NBME is so they're the ones really responsible. Why is it? Are we good now? Can we? I don't know if it's working. Okay, and then the video output is low. Let's make that HD. Alright, let me know if is it all clear? Okay, perfect. Thanks a lot, guys. So what I was saying to answer Hussein Zain's question is that no matter what medical test you're really studying for, definitely do UWorld and Amboss, because these two guys have excellent questions, and then they explain the right and the wrong answer choices. And that's one of the most important things when you're studying through questions. You got to understand why they are the way they are. Yeah, but it still helps. It still helps. And of course, there really isn't a question bank that's directly for IFOM as far as I know. So I would do that, you know, because in the long run, you definitely need to learn what's in UWorld anyway. So just use UWorld. If you know the more advanced stuff, the easier stuff also becomes very clear. So that's the best I can say. But if you know other people that are going to have to take the IFOM, maybe they can guide you a little better. 527. So let's look at this basal cell carcinoma stuff. Alright, so this was a cool thing that they did in 2019, right? So basal occurs above the upper lip and squamous occurs on the lower lip and below. So this patient had the basal cell carcinoma, right? And they tell you that it's on his nose, right? Where they say, yeah, on his nose, which is above the upper lip. So that's how you know it's basal. Well, that's one of the ways you know it's basal. Locally invasive, as we saw. Waxy pink pearly nodules with telangiectasias and rolled borders were not explained, right? Nor the central crusting ulceration. None of that was given. Then they gave you the histological explanation, which was talking about this palisading nuclei, right? If you look at image D, this is what they're talking about, right? So this is a fence right here. That's your fence. That entire thing you're seeing right here, that's your fence. Those are all nuclei that are causing a fencing to be formed. That's how you kind of want to think about it. You can find many images of palisading nuclei. Now, spend good time here, because all of these are really, you know, you should be able to look at the image and tell me what's wrong with the patient. That's what you want to be able to do. Look at the image and then be able to tell what's wrong. And a lot of them are dark because they are pigmented, right? And that's another way to help you kind of pick out answer choices. So this wasn't so bad. And we talked about the nevus a lot too, because that was also another question. I don't remember if it was NBME or if it was just because we did the nevus in our musculoskeletal dermatology videos, but the nevus was something we talked about a lot as well. 36. A 6-month-old girl is brought to the emergency department by her parents because of vomiting for 6 hours. She has been feeding poorly for 1 day because of an upper respiratory tract infection. So 6-month-old girl, feeding poorly, upper respiratory tract infection. Temperature is 98.6, so it doesn't look like she has an infection right now. Pulse is 100 per minute, respirations are 18, blood pressure is low, physical exam shows lethargy and a clear nasal discharge. And then you do lab studies, you see high ammonia. You also note high urine uric acid. This patient most likely has a deficiency of which of the following enzyme activities? Okay, so if your urine uric acid is increased and you have hyperammonemia, that is OTC deficiency. OTC, ornithine transcarbamylase, converts carbonyl phosphate to citrulline. This patient has low citrulline, right? That's also given, decreased citrulline. The hyperammonemia shunting ammonia toward making more glutamine is the reason you have more glutamine. So the patient is low on alpha-ketoglutarate and low on GABA, which is why she has the symptoms she has. Her symptoms are due to a lack of TCA and GABA. I can't do the TCA cycle without alpha-ketoglutarate. This is unusual that it's a girl because OTC deficiency is X-linked, so NBME is just being an asshole here. Orotic aciduria would not have hyperammonemia because orotic aciduria is more of a anemia thing, right? It's under Hem-Onc, and that's only because you can't make UMP, so you just give them the UMP stuff, right? That's how you treat them. So if we go to page 82, we can see, and you should be really confident with this stuff, right? You should be, what did I just do? Page 82. You should be very confident with the urea cycle, right? You have your carbon dioxide and NH3, CPS1, carbonyl phosphate synthetase 1, makes carbonyl phosphate. Then you have OTC that takes the carbonyl phosphate and makes citrulline. Okay, this enzyme, if it's not there, right, that's ornithine transcarbamylase deficiency. It's the most common urea cycle disorder. X-linked recessive, and it interferes with the body's ability to eliminate ammonia. Right, so then hyperammonemia, remember I told you guys to revise the urea cycle and hyperammonemia when you're done with GIT, right, because it's all very relevant at that point. And right here, hyperammonemia, what happens? Well, if you have a lot of NH3, you need to get rid of it. One way to get rid of it is to combine it with alpha-ketoglutarate to make glutamate. And then another way to get rid of it is to take all that glutamate, combine it with more ammonia, and make glutamine. So hyperammonemia patients will have high amounts of glutamine and run out of glutamate and alpha-ketoglutarate. So they don't have GABA, they can't do TCA, and that's how you see symptoms in hyperammonemia patients. There are many things that can cause hyperammonemia, so you have to know those. One of those is this thing, the lack of OTC. All right, without OTC, you're going to back up and have too much ammonia here because you're not using it. You're not going into here. All right, so that's what happened with this patient. Really straightforward. The other thing, the orotic aciduria thing, because they have ornithine transcarbamylase is the last answer choice. Arginase deficiency also is related. Arginase deficiency is another thing. But arginase deficiency does not have hyperammonemia. That's what you need to remember. Arginase deficiency, as you can see from this note right here, is something that's discussed in UWorld too. But by the time you've reached here and you've made arginine, that means you've already made citrulline, you've already done all of this steps, so far. That means you used up your ammonia already. You took the ammonia, you made citrulline, you made arginine succinate, you made arginine, but then you have arginase deficiency, so you're unable to make the ornithine again. All right, so that's what we're seeing here. Arginase deficiency. Okay? No hyperammonemia. Very important to remember that. So you wouldn't be confused. A lot of students were confused because they're like arginase and OTC are both part of the urea cycle. So that means neither of them must be the answer. Well, although they're both part of the urea cycle, they're parts of different parts of the urea cycle. It's a difference to be the first guy and then be a different guy. So just because you're part of the same cycle does not mean you can't cause the same issues. So arginine succinase is also in the cycle. CPS, carbonyl phosphate synthetase, could not be the answer because they told you citrulline was high. Sorry, low. Citrulline was low. Wait, what am I saying? Hold on. It's so hard doing these questions, guys. I get so exhausted by this point. It's like really hard to not make mistakes, so excuse me. What was I saying? Yeah, okay, CPS. Why can this not be the answer? Carbonyl phosphate synthetase. Why is this wrong? Well, they tell you that the urine orotic acid is increased, right? You have orotic acid. So if you have orotic acid, right, that means that you've already gone past this step over here. And that's something you want to make sure you remember, because you're already doing this. You make carbonyl phosphate. Now you have increased orotic acid in your urine, right? CPS1 is just an extra guy out here. It's almost never the answer. It is the rate limiting enzyme, but it's almost never the answer for what's missing. It doesn't happen. So that's another asshole thing they did to put this as an answer choice here. This thing is irrelevant, and I guess that's about it. So for the most part, at least you could see everything here is urea cycle related. The other thing they could have done is they could have put one of the answer choices that are related to orotic acid urea. So orotic acid urea would be the other issue, but that causes megaloblastic anemia. Always remember that. Orotic acid urea is just an inability to convert orotic acid to UMP. That's because you don't have UMP synthase. So to treat it, you just give them that. You give them uridine monophosphate, and they'll have it, and they'll be okay. They'll get through it, right? No hyperammonemia. No hyperammonemia. Okay, but in ornithine transcarbamylase deficiency, you do have increased orotic acid with hyperammonemia. So that's it for that part. This question. A physician is assigned to a search and rescue team attempting to locate and recover the victim of a light plane crash with only the pilot on board. The plane crashed in a remote mountainous region of Alaska and has been missing for more than 2 weeks. A search helicopter detected what was believed to be a signal from the area of the downed plane and has picked up the pilot, so he's still alive 2 weeks. Okay. The pilot has only minor injuries but has complications of exposure and has lost a considerable amount of weight. While the pilot was able to locate a good water supply, he had no food during this period of isolation. The pilot most likely has which of the following conditions at this time? And then you look at your answer choices, and this is kind of when you sort of give up because you're like, I've never heard of this before, right? Nitrogen retention and nitrogen balance. What is this related to? So you might know about it from something else, or you might have never ever heard of this and have no idea what's happening here. The answer here was C, a negative nitrogen balance. Okay, so what is this? Negative nitrogen balance is associated with burns, serious tissue injuries, fevers, hyperthyroidism, wasting diseases, and during periods of fasting. This means that the amount of nitrogen excreted from the body is greater than the amount of nitrogen ingested. Makes sense, right? So negative nitrogen balance basically is like a bank account with a negative balance. You lost more nitrogen than you made. A positive nitrogen balance is associated with periods of growth, hypothyroidism, tissue repair, and pregnancy. This means that the intake of nitrogen in the body is greater than the loss of nitrogen from the body. So there is an increase in the total body pool of protein. That's it. So it's a really unorthodox set of answer choices, but that's what they mean. Nitrogen is usually related to amino acids and protein anyway. So, through intense clarity and really good logical thinking, you could come down to negative nitrogen balance, as in you would have a negative amount of nitrogen or low nitrogen in your body because you're going to have low protein. For 2 weeks, all this man had was water, right? And then the increased nitrogen retention and decreased nitrogen retention don't really make sense. Nitrogen retention is not really a thing. Right? So you're really just between C, D, and E. 38. A 62-year-old woman comes to the physician because of a 3-year history of a mild cough that has produced purulent sputum for the past 2 weeks. She has smoked 2 packs of cigarettes daily for the past 42 years. She drinks 3 to 6 beers daily. Findings on physical exam show swelling of the metatarsals, metacarpals, and proximal phalanges. X-rays of the affected bones show new bone formation. There is also arthritis of adjacent joints and clubbing of the digits. Clubbing of the digits, okay. Which of the following is the most likely underlying disease? So clubbing of the digits was the only weird thing here, right? Everything else kind of seemed like arthritis stuff, right? Then they tell you clubbing of the digits, and that's when you start thinking something is off. Remember, clubbing, the thing that you check by doing the shamrock sign, clubbing is a sign of hypoxia. And now you look at all your answer choices and you would pick one that has something to do with possible hypoxia. The only things that are here related to the lung are your bronchogenic carcinoma and interstitial pulmonary fibrosis. Alright? So if you're going to pick something, you should pick something between those two answer choices and hope you pick the correct one. This question was about hypertrophic osteoarthropathy. This patient most likely has adenocarcinoma of the lung, leading to abnormal proliferation of skin and bone at the distal extremities. It is very easy to think F can be the answer and that this may be Kaplan syndrome, but they did not mention rheumatoid nodules, right? Rheumatoid arthritis. Adenocarcinoma can have activating mutations of KRAS, EGFR, and ALK. So hypertrophic osteoarthropathy, what is that? That's actually mentioned in a list of diseases that are never mentioned again on this page. Paraneoplastic syndromes, right? 229 of pathology neoplasia. So a lot of these are rare. You've seen questions of Steiner of Lesser-Charlotte. You've seen acanthosis nigricans, right? You've seen some dermatomyositis as well. We've seen hypercalcemia, Cushing, and hypernatremia. We know the endocrine neoplasms really well. This is discussed a lot in respiratory. We know some of the hematologic ones very well because they're discussed under hemonc a lot. The neuromuscular ones, we only know Lambert-Eaton and myasthenia gravis. These two are discussed. That's it. Right now, these other four here, and then this guy are the only things. There's 5 of them then that you just have to know separately. They're not really discussed ever anywhere again. So hypertrophic osteoarthropathy is an abnormal proliferation of skin and bone at the distal extremities, and you get clubbing, arthralgia, joint effusions, and periostosis of tubular bones. Really is going to be associated with an adenocarcinoma of the lung, so at that point the only thing you could pick is bronchogenic carcinoma. That's it. Alright? So what are these other guys? So that was hypertrophic osteoarthropathy. These other guys down here, a patient with an ovarian teratoma can present with these things. Psychiatric disturbance, language dysfunction, dyskinesias. That's because of anti-NMDA receptor encephalitis. So you have to remember that. Or it can be the other way too. You can get a patient presenting with these things out of nowhere, and then the question is going to be like, what might the patient have? She might have an ovarian teratoma. Right, so I made up a thing, no men or dicks allowed, ovarian territory. Right, so NMDA, you get a psychiatric disturbance female. This is also pretty common. Opsoclonus myoclonus ataxia syndrome, often described as dancing hands, dancing feet. They'll tell you in the question stem the eyes are moving really weirdly. The patient is having some kind of seizure type feet movement. It's related to neuroblastomas in kids and small cell lung cancer in adults. Paraneoplastic cerebellar degeneration was actually a topic UWorld had a question about. It's antibodies made against Purkinje cells, and it's related to many different things. It could be a patient with small cell lung cancer making anti-WHO antibodies. It could be a female patient with gynecological breast cancers making anti-YO antibodies. Or it could be any other patient with Hodgkin lymphoma making anti-TR antibodies. So I just made up this thing to memorize that, but all of these are related to paraneoplastic cerebellar degeneration. All right, and then paraneoplastic encephalomyelitis is another encephalitis kind of thing, but this one is related to small cell lung cancer. All right, so you have to spend some time really getting these down because you can get weird questions that don't seem to add up in any way. And this is definitely one of them. There's a weird question that doesn't add up. It's really easy to go ahead and pick that the underlying disease is rheumatoid arthritis. Like I said, Kaplan syndrome is related to the lung as well. But this wasn't a rheumatoid arthritis question. All right, definitely not a rheumatoid arthritis question. 39. A 48-year-old man is brought to the emergency department 12 hours after taking a massive overdose of ferrous sulfate. Serum sodium and potassium concentrations are within the reference range. which of the following sets of serum concentrations is most consistent with this overdose? So massive overdose of ferrous sulfate. So iron overdose, right? What happens in an iron overdose? That's all they're trying to figure out here. Iron tablet overdose is one of the mud piles. It's the eye of mud piles. So you're going to have a high anion gap metabolic acidosis. Number one, first you're going to have mitochondrial toxicity because of the iron. That decreases aerobic respiration and shunts everything to lactic acid production. Number two, you're going to have cardiotoxicity, secondary to the mitochondrial toxicity, leading to cardiogenic shock, also causing more lactic acidosis. Hepatic toxicity will decrease the lactate metabolism, adding even more to lactic acidosis. When in the trivalent form, Fe3+, which is ferric, it can react with 3 molecules of water to make FeOH3, 3H+. This will then deplete bicarb buffering system, resulting in the non-gap acidosis. Right, but that doesn't happen here. Here we have ferrous, which is Fe2+. So these are just extra facts to know, and the patient will have answer choice B. Chloride of 96, bicarb of 8. Right? When you saw all these other bicarb choices, you could knock out A and D because they were too high. You need the bicarb to be low. Alright? So you can just go pick B just off of that. 28 is pretty much normal bicarb, so it couldn't be that. Alright? So high anion gap metabolic acidosis. So your bicarb had to be low. And it was just B. They gave pretty good answer choices, especially considering not many people tend to remember what happens with chloride. Alright? So that was all there was for this question. Number 40 has this image with it. 28-year-old woman at 32 weeks gestation comes to the physician because of a 4-day history of fever and back pain. She says that during this time, she also has been crying frequently. Okay? Her temperature is 100.4. Physical exam shows claustrophrenic angle tenderness. The photograph shown represents her disease. Okay? Which of the following mechanism is the most likely cause? Alright, well, she has claustrophrenic angle tenderness. And she's pregnant. 32 weeks gestation. Fever and back pain. So, if you look at this photograph, you're basically seeing all the tubules are full of stuff. There's mad stuff inside all of them. That's not supposed to happen. Chorioamnionitis would be something after delivery. Endometritis would not be represented by a photomicrograph of her kidney. This is definitely the kidney. Glomerulonephritis doesn't make sense. Hematogenous infection. Well, her temperature is very high, so I can see how someone might pick this. But the photomicrograph doesn't display infection. And they told you that the photomicrograph is showing her disease. Obstructive uropathy or PID, pelvic inflammatory disease, would not have a high temperature like that. Nor would it just have claustrophrenic angle tenderness. So the answer here was E, obstructive uropathy. Right? This is hydronephrosis that you're seeing in this image here. During the last half of pregnancy, dilation of the upper urinary tract can occur due to compression of the ureters by the growing fetus and the linea terminalis. The compression of these is not allowing fluid passage into the bladder, causing urine buildup in the kidneys. This leads to dilation of the kidney that ends up causing symptomatic hydronephrosis. This can end up in infection and symptoms such as the ones present in this patient, like back pain and costovertebral angle tenderness. The crying is mainly due to the pain caused by the obstruction, and just as something extra, double pigtail catheters is a safe and simple way of treating symptomatic hydronephrosis of pregnancy. You just put the catheters in and you drain all the pee out. So costovertebral angle tenderness was the clear giveaway, cueing you into a renal or ureteral problem, and E is the only renal or ureteral problem. C, glomerulonephritis, has nothing to do with this patient. Alright, so you could only pick E. The other answer choices really did not work with the photomicrograph given. And if we go to page 652 really quick, this is hydronephrosis, you see? So it can also be due to a stone here, a kidney stone. So you see how everything's just, the calyces and all of that, they're expanding. Distension. So that distension is a sign that is related to some kind of obstruction. All right. Congenital obstruction. Okay. So they don't even have it here that it could be due to pregnancy, but it can be. Yeah, the fever was definitely a giveaway for other stuff, right? Fever was kind of weird. But remember, two things are more important. Yes, sure, they gave a fever, and it does seem weird. You know, I don't really know why she has a fever. She might actually have infection too. She might. But the image they gave you is not of pyelonephritis. There's two things. One, they tell you that it's only one side, right? Claustrophrenic angle tenderness, it's not both sides. They don't say it's bilateral. It's just going to be a one-sided thing, and it's because her one-side ureter is being obstructed by the growing fetus. That's what you wanted to imagine here. So everything backed up. She could have infection. She could have infection, but that's not the main issue here. Right? The most likely cause is the root issue here is the obstructive uropathy, which could then cause infection, and it wouldn't be hematogenous infection either. So that's, yeah, it's a pretty interesting way to really like make sure you know your stuff. It's pretty weird. This one was really easy. So a 23-year-old woman comes to a physician for a follow-up exam. She underwent a median sternotomy for repair of an atrial septal defect 3 months ago. She is otherwise healthy. Her last visit 6 weeks ago showed a well-healing surgical incision. Physical exam today shows expansion of the scar tissue beyond the edges of the original incision, which by definition is a keloid. An abnormality in which of the following processes is the most likely cause of these findings. So it's just abnormal collagen synthesis. That's it. A lot of people wanted to pick epithelial proliferation. No one picked fibrin deposition. No one picked granulation tissue formation. Actually, some people did. Some people also picked D, granulation tissue formation, not neovascular and not neutrophil. So in the end, in all honesty, this is kind of between A and D, but a keloid is just A. It's uncontrolled almost collagen synthesis. So if we go back and look at that, there's something you want to be very clear on. So you can have scar formation, hypertrophic or keloid. The hypertrophic is the normal scar you get. This is a really, really bad case of a keloid here. Right, disorganized collagen synthesis, both types 1 and 3. All right, but that's it. It's just the collagen synthesis, not exactly granulation tissue formation. That's not what's happening here. Okay, so there's something called contractures. Contractures occur when unusually high MMP, metalloproteinase activity, results in excessive wound contraction. And they talk about that a lot. These are all questions here related to the same topic from UWorld. You see the UWorld question also has the same answer: excess collagen formation. Alright, and they again talk about normally wound contraction, a normal part of proliferative phase of wound healing, involves contraction of actin in the myofibroblast to approximate wound edges. Transformation growth factor beta, TGF beta, promotes differentiation of fibroblasts into myofibroblasts and should diminish on completion of wound repair. In keloids, TGF beta is produced excessively without regulation, so keloids extend beyond the borders. Right, so TGF beta and the whole concept of contractures, which is basically, I also think of it as like a contractor that works on buildings. You got to measure everything. You got to measure everything and build it correctly. If you didn't measure correctly, you build excessively, it comes out to be too big. You know, that's kind of what's happening here. A 52-year-old man is brought to the emergency department because of a 4-hour history of a severe headache, anxiety, sweating, and palpitations. He has a 2-year history of hypertension well controlled with clonidine and hydrochlorothiazide, but he ran out of his prescriptions 3 days ago. His pulse is 120 per minute, blood pressure is 170 over 110. Physical exam shows diaphoresis. Which of the following effects is most likely to follow after being given a beta blocker like propranolol? That's all they want to know here. What do beta blockers do? So you have to remember beta 1 receptors, heart rate, right, contractility. So you look at your answer choices: decreased total peripheral resistance and decreased cardiac output. Well, a beta blocker would cause decreased cardiac output, right? So we can definitely knock out B. B says increased cardiac output, so we can knock out B. We can knock out D, which also says increased cardiac output. A beta blocker would decrease your cardiac output. all right, because of contractility. So between A and C, are you going to have decreased total peripheral resistance or increased total peripheral resistance and a decreased cardiac output? So the correct answer for propranolol was C. Propranolol is a non-selective beta blocker. Beta 1 stimulation increases heart rate, therefore blocking it will decrease heart rate and thus cardiac output. Beta 2 stimulation causes vasodilation, therefore blocking it will cause unopposed alpha 1 activation, therefore causing total peripheral resistance to increase. So you would increase the blood pressure. C. That's it. That's all you had to think of it as. Nothing more. Don't complicate it. The patient was previously on clonidine, which is one of the few alpha-2 agonists, which would help with the hypertension by decreasing sympathetic outflow. But he ran out of clonidine, so he has high sympathetic outflow now, which means the alpha-1 vasoconstriction will definitely be overwhelming. Clonidine is a very unique special medication. There aren't that many alpha-2 agonists to begin with. 42 is done. All right, 43. 45-year-old man is undergoing a surgical procedure. Which of the following maneuvers by the anesthesiologist would result in an increase in intracranial pressure? So which one of these things would increase intracranial pressure? That's all you need to know. And you might not know. Right? Increasing intracranial pressure is related to a lot of things. There's the CO2, there's the oxygen. So let's take a look at the explanation stuff, right? Hyperventilation causes a decrease in CO2, which subsequently leads to arterial vasoconstriction and lowers the cerebral blood flow, cerebral blood volume, and intracranial pressure. But we're trying to increase intracranial pressure. He wants to increase ICP, which he can do by decreasing the respiratory rate, hypoventilation. Right, so CPP is equal to MAP minus ICP, and if CPP was 0, cerebral perfusion pressure, if that's 0, there's brain death. So if you increase ICP, that would be dangerous, right? Because mean arterial pressure is just your mean arterial pressure. Increasing intracranial pressure is a scary thing to do. If you do that, these two numbers might become equal to each other, and 10 minus 10 is 0. So how do you increase your intracranial pressure? Just increase airway pressures. If you increase airway pressures, you will not be able to breathe that well, right? You're going to hypoventilate. That's all this was. Decreasing the respiratory rate was a trick answer choice. All right, just a trick answer choice. I can't explain why it's wrong. I don't know enough to explain why it's wrong, but increasing airway pressures is really the thing you kind of do, right? Remember, we're talking about pressures here, so you want to work with pressures, not rates. And decreasing respiratory rate is not really a thing you can do. Like, there's no actual way to do that per se, unless the person is really just reliant on a machine to breathe, and then the machine kind of slows down the breathing rate. But for this, the correct answer was increasing airway pressure, right? Increasing respiratory rate and decreasing respiratory rate were both answer choices that were also there, and they're weird answer choices, but they can, when you think logically, they can kind of help you guide yourself the right way. But remember, everything's about pressures. So yeah, that was D. Increasing airway pressure. Okay, this one was also an easy question, but a couple people were pretty confused about what's happening. So immediately after a cerebral infarction, a 62-year-old right-handed man has decreased fluency of spontaneous speech, with phrase lengths of less than 4 to 5 words. His comprehension is normal. Neurologic exam shows weakness of the lower 2/3 of the face on the right. This patient most likely has a lesion in which of the following labeled areas in the drawing of the brain. So this is just this area right here, right? This patient is presenting with Broca's aphasia. He cannot speak fluently, but he understands fine. Understanding would be Wernicke. Wernicke would be, let me show you. So if we go to page 543. So we've talked about this already as well. So this stuff is your Broca and Wernicke. But let me show you even better. Where did I bring that page? I should have put this page. This is 560. Oh, 560. Okay. So what you really want to pay attention to is the fact that the description is the man, I like the 2018 book better for aphasia. But basically, it's this is the lower part of the frontal lobe. That's your Broca, and the upper part of your temporal lobe is Wernicke. Right, that's something how you want to remember. So due to infarcts in the superior division of the MCA, you can get Broca. Our superior division of the MCA causes Broca, and the inferior division of the MCA can cause Wernicke. Right, and that's kind of what this patient might have too, which is why he's got multiple symptoms, not just the aphasia stuff. But Broca is always going to be the lower part of your frontal lobe, and Wernicke is the upper part of your temporal lobe. So here, right, A is Broca. These guys are not Broca. None of them are Broca. Also over here, E, a lot of people thought was Wernicke, but it's actually G. G is the Wernicke area, right, not E. And F is just your occipital lobe area stuff, so that's not going to be relevant here. A 45-year-old man comes to the office for counseling prior to bariatric operation for weight loss. He was recently diagnosed as pre-diabetic. I have to rush now, so I'm just going to run through the last 5 now. He's under 70 centimeters tall and weighs 116 kilograms. BMI is 40. Physical exam shows no abnormalities. In addition to recommending the patient follow a balanced diet, it is most appropriate for the patient to avoid ingesting excessive amounts of what? Okay, so anyone that's trying to lose weight in general should be avoiding starchy foods. So this question is about, so online people told me this question is about dumping syndrome. I didn't really need to know anything about dumping syndrome. It makes sense to just avoid starchy foods. Like, you avoid rice to lose weight, right? So you avoid starchy foods and you're done. You don't avoid gluten-containing foods, green leafy vegetables, avoid nuts, or avoid proteins. Those are not things you avoid when you're trying to lose weight. 46. A 47-year-old woman comes to a physician because of a 6-month history of increasingly severe cough and shortness of breath. She's had no fever, chills, or muscle aches, does not smoke. So she just has increasing severe cough and shortness of breath. Okay. She works as a librarian, often exposed to dusty books. Lives alone with 4 parakeets, became a vegetarian 2 years ago, is an avid knitter, can spin her own wool. Crackles are heard in the lower lung fields. Lab studies show an ESR of 40. Chest x-ray shows reticulogranular changes. Examination biopsy of the lungs shows interstitial infiltrates of lymphocytes and granulomas. Oh yeah, okay, yeah. So this is a giveaway. It's going to be the C with the parakeets. I don't have too much time to talk about it, but hypersensitivity pneumonitis is what the question is about. Page 745. Wow, how did today's lessons end up being so long? So this is this thing. This is what they're describing. This is your hypersensitivity pneumonitis. It's a mixed type 3 and 4 hypersensitivity reaction to environmental antigens. Causes dyspnea, cough, chest tightness, and headache, often seen in farmers and those exposed to birds. Reversible in the early stages if the stimulus is avoided. And this is what they're describing from their histological thing, right? The biopsy. Interstitial infiltrates with lymphocytes and granulomas. So this is a really hard question for anyone who forgot hypersensitivity pneumonitis. But it wasn't any of these other answer choices. They just wouldn't fit. Note that none of the answer choices really fit, and this seems weird at first because it does not fit any obvious diagnosis. Then consider hypersensitivity to parakeets must have been the trigger that made things worse over 6 months. Right? Even if you didn't know what hypersensitivity pneumonitis is. And contact with parakeets is the only thing you could really pick at that point. A 65-year-old woman with cardiovascular disease is found to have multiple small cholesterol gallstones. Okay. She's considered a poor candidate for a cholecystectomy. The most appropriate treatment for this patient is a drug that would cause which of the following biliary changes? So, which of these changes would be good for a person who has gallstones? How do you get rid of gallstones? So here the answer was D. Bile salts help dissolve gallstones that have formed in the gallbladder, used in patients refractory to surgery or preferred to avoid it. Ursodiol increases bile salts, and this is a very common medication used in patients who have gallstones for whatever reason and can't get surgery for whatever reason. Some people just can't get surgery for multiple purposes. Some people also deny getting surgery. Some people cannot afford surgery. So either way, ursodiol is the medication you give to get rid of gallstones. That's something you have to remember and know. And then the mechanism of action of ursodiol is to increase bile salts. It decreases biliary cholesterol by suppressing hepatic synthesis and secretion of cholesterol, as well as inhibiting intestinal absorption. So basically, you lose all your own cholesterol, and now you have to make new cholesterol, and there's a bunch of other concepts to that. The other answer choices are not related to getting rid of gallstones. An investigator wishes to determine the effectiveness of a new preparation of candy containing citric acid, which is substance. Wow, I love how these last few questions are all long as fuck. I gotta fucking go, man. Oh my god. Okay, whatever. Candy containing citric acid substance X as therapy for Sjogren's syndrome. Okay. Both substance X and a placebo, which does not contain citric acid, are administered to healthy volunteers. It is found that substance X produces twice as much saliva as the placebo does. However, analysis of the ionic composition of the saliva shows that the saliva of the placebo group contains half as much sodium chloride as that from the substance X group. So already by now, if you're as exhausted as I am, you're like, what the fuck is this question? In contrast, the concentration of bicarbonate is almost the same in both groups. Which of the following best explains these findings? So then you have these weird answer choices that further confuse you. You're like, what the heck is happening here? There's really no way to answer this question. And if you're running out of time and this is actually number 48 for you and you might have like 3 minutes left, just pick something and skip it. Pick anything and skip it, because this is a really ridiculous question. So the correct answer here was D. Ductal ion reabsorption is more efficient at a low flow rate. Flow rates and stuff like that, this is such an unorthodox thing to test you on if the question is just about Sjogren's syndrome. What they're saying here is they're making a candy here that kind of helps you make more saliva. That's basically what's going to happen there. And that's something that will help these people, because in Sjogren's syndrome you have no fluids. You don't make tears, you don't make saliva, none of that. It's completely dry patients, right? So a low flow rate means that you're going to have high concentrations of potassium and low concentrations of sodium, bicarb, and chloride. Whereas at high flow, when you're making a lot of saliva, low concentration of potassium, high concentrations of sodium, bicarb, and chloride. And then the rest of the explanation is there for you to read by yourself, but this question was just really stupid. It's just unnecessary. 49. A 25-year-old woman is brought to the emergency department after collapsing in the ICU where she works as a nurse. Co-workers report that she had appeared fine all morning, but shortly after lunch she became pale and diaphoretic and then collapsed. She has a history of several episodes of confusion and autonomic symptoms associated with hypoglycemia that occurred at various times of the day without apparent precipitants. She is unresponsive, her temperature is 98.8, pulse is 96, respirations are 18, blood pressure is 100 over 60, finger stick shows the blood glucose is really, really low. A bolus of 50% dextrose is administered. Lab studies now show what you see here. Right, so her C-peptide is very low, pro-insulin is also low, but her free insulin is really high. Okay. She's a nurse too, so this is a giveaway for factitious disorder. This is a really obvious. First things first, the patient is exhibiting Munchausen syndrome. Her low C-peptide and proinsulin levels indicate that she has exogenous insulin intake, and many nurses are known for doing this. It's just a weird psychological thing, so it's a really easy question. It's not an insulinoma, nor is it some kind of any other disorder that they've listed here, because if you make insulin, then your C-peptide level would match your insulin level. It's a part of insulin. If your C-peptide is really low and your insulin is high, that means you've been injecting yourself with insulin. And that's what this patient is doing. That's why she was so hypoglycemic. Last question. A 23-year-old woman sustained significant blood loss in a motor vehicle collision. She's given 3 units of blood and has an uneventful recovery. 4 weeks later, she becomes jaundiced. She's afebrile. Lab evaluation shows anemia and reticulocytosis. No evidence of infection. Which of the following additional studies is likely to be most useful in establishing the diagnosis? So, read the question carefully, right? Which of the following additional studies for establishing a diagnosis? So first things first, what does she even have? And then you figure out what you can do. So she had lost a lot of blood, they gave her blood, but then she became jaundiced and afebrile 4 weeks later. So what we're trying to see is she reacting to the blood she was given, right? She's got anemia and reticulocytosis, which means she's making reticulocytes, but for some reason something's not right here. So you look at all your answer choices: direct antiglobulin test, hemoglobin electrophoresis. Okay, hemoglobin electrophoresis is only done to look at what kind of hemoglobin you have, like for sickle cell and stuff like that. That doesn't work. Serum conjugated bilirubin, bilirubin concentration is really just going to help you figure out if a patient has direct or indirect bilirubinemia, but she doesn't have a bilirubinemia per se. That would have been an issue for her before she even got the blood test done. I mean, the blood loss and the new blood being given to her. Ferritin concentration is for iron deficiency or hemochromatosis. Same thing for transferrin. Serum erythropoietin concentration would be something you would do to check for polycythemia, not anemia. Alright? So after all of that, it comes down to just a direct Coombs test. It would detect antibodies bound directly to the red blood cells. Hemolysis is most likely due to something in the transfused blood. Not sure why it took 4 weeks when the type 2 is supposed to be quicker, but that's just NBME doing stupid stuff. Immune hemolytic transfusions reactions occur due to mismatch or incompatibility of the patient with the donor products. Immune hemolytic transfusion reactions are divided into acute versus delayed. Acute ones occur within 24 hours, delayed ones happen after 24 hours. The delayed reactions usually occur 2 weeks after but can go up to 30 days post-transfusion. The severity of the hemolytic reaction is dependent on the type and quantity of antigens, and all you have to do is do the direct antiglobulin test and you would confirm that she's reacting to the blood. Alright? So thanks a lot for joining. I really hope that this entire NBME thing has been very helpful. Next, I'll be starting up with NBME 23 since I'm done with the explanations for that. So thank you very much and keep it up, guys.